So very good morning, everyone, and thank you for everyone to be over here on a Sunday morning. So I'll be talking about a few tricks that anterior segment surgeons can perhaps use in case if they land up in soup. Tricks that perhaps are more, they come more naturally to a VR surgeon. So just an irony, so when you're catching small fish in calm waters, it's pretty easy, but so is operating a straightforward cataract. But it's essentially catching these big fish with the same technique out in the ocean that is not always yield a good catch, and similar to that in cataract. So, but what if the instruments that are used in deep sea fishing are applied to surface fishing? And as we all know, vitreoretinal surgeons are expert divers in troubled waters. We have ultra sharp, ultra small instruments. So a change in strategy and instruments in difficult situations, it does hold promise of good results. So similarly, we'll go through a few scenarios. A traumatic cataract with a fibrosed anterior capsule, as you can see over, it's extremely difficult to even make an opening and then extend the rhexis. So again, using a retina forceps over here, an end grasping forceps over here, using a retinal scissor over here to make multiple cuts and then grasping it repeatedly to make sure that you have some sort of a capsular rhexis that you can make over here. Sometimes the end grasping forceps gives you a better grip as compared to even a microrhexis forceps. Similarly, another case where you're making a rhexis and then it extends. So again, in such a situation, I personally like to use an end grasping forceps. Of course, you need to use a combination of different forceps and instruments so as to give an optimal outcome. As you can see over here, now it's extended and then gripping it and then pulling it back. And you have a good rhexis that you can proceed with with phaco. So another similar case, I'm going to skip this now because we've quite overshot time, because it's essentially the same. Now, many a times you have these traumatic cases where you've got fibrotic membrane stuck to the cornea, and again, removing them can be a challenge sometimes. So again, using two instruments, micro instruments that we use as retina surgeons, like you see over here, a forceps and a scissor, and then using it bimanually and grasping onto the fibrotic membranes with your end grasping forceps and using a scissor to begin cutting these membranes. It makes it easier for us to remove them. Corneal opacity cataracts again can be challenging sometimes, and of course, transillumination that we all spoke about earlier has been the way that additional visualization was given, wherein you're using endo illumination from the outside, where your assistant is holding it. Another way is using a chandelier illumination, which essentially gives you an actual retro illumination, as you can see over here. So you see, it's going to be a difficult scenario. So putting in a chandelier illumination, a 25 gauge chandelier illumination over here, gives you a good retro illumination. You can switch off the microscope light and it gives you additional clarity. As you can see, it's easier to remove those phaco pieces, less chances of complications that can happen. And whenever you want, you can obviously switch on the light, as you can see in the next case. I need to thank my dear friend, Dr. Somil, for this beautiful surgical video. So again, putting in a chandelier illumination, and then you can see how nicely you can visualize your rhexis. At any particular point of time, you can switch on and switch off between your microscope and your illumination. It's especially tricky in the area where you have those corneal opacities. And after that is done, again, the steps are going to remain the same. It's essentially just a matter of better visualization. So now the illumination has been switched off. And again, there's slight confusion about the phaco over here. And then you switch on the illumination, and that gives you good visualization. And once this is done, most of the difficult part is over, and then you can implant the IOL. Now, you have these small eyeballs many times that, there's a very big, there's a huge buildup of posterior vitreous pressure, and the space to operate in the anterior chamber is quite less. So in such situations, one good technique that I again learned from Sawmill is, again, it's a small pupil as well over here. So after putting in iris hooks to increase your field of view, what we do over here is put in a 23 gauge, 25 gauge, or 27 rather, a sclerotomy port, do a little bit of core vitrectomy that bulks the vitreous, central vitreous, and brings down the pressure temporarily. You can put the plug back, or use a valve cannula, and then go ahead and operate like a routine phacoemulsification. Obviously, you have to be a little careful because there can be sudden build-up of pressure, and anytime there is a build-up, you can do a little bit of core vitrectomy and reduce the posterior vitreous pressure. Chances of complications are comparatively, I'm sure everybody has encountered situations like these, wherein you, if you anticipate it, you can use mannitol and you can use Dimox, but on table, if this happens, this is a good way to counter that problem. As you can see, there was a little bit of pressure build up again, a little bit of vitrectomy that was done, and after the lens is out, putting the IOL in, and then one can remove this sclerotomy port. So there was a lot of discussion on iris claws. So this is another technique I learned. I've not done too many of these, but instead of putting it, holding the iris claw with the iris claw forceps and then holding it and then enclaving it on either side, another technique that Sawmill came up with was pushing it in and then keep moving the lens in the position that it has to be fixated, and then going in from the side port, holding the haptic, and then using your second instrument to enclave it, and then repeating the same procedure on the other side. That kind of reduces the pressure that you put on the globe. So there are these cases of capsular phimosis that you end up with. So using a retinal scissors sometimes can be quite easy over here to make multiple cuts and then use your vitrectomy too. Now, of course, you have these posterior chamber plaques sometimes after you put in an IOL, and most of the times you end up using a cutter to eat away the plaque. What you can also do is use an MVR, slightly bent MVR, and try to scrape off the plaque. In case if it, most of the times you're able to remove it. In case if there is a complication, you always have the cutter to remove the central, the posterior capsule. So the take home over here is essentially that, just like Dr. Sawmill had shown, there are multiple ways of bringing the nucleus out or removing it inside. You have multiple ways of tackling these problems that you commonly encounter, and simple techniques and simple modifications can offer solutions to all of these. So thank you very much.